Welcome to the November edition of the ASC eJournal presentation. I'm Dr. Reid, the chair of eJournal committee, and I will be moderating this session. I will start with a brief introduction of our presenter, Dr. Sadia Sayeed, who is a member of the eJournal committee. She is the director of cytopathology, as well as the program director of cytopathology fellowship at VCU in Richmond, Virginia. Her clinical interests are surgical pathology and cytopathology with a focus on ultrasound-guided FNA. We are also grateful to have with us the authors of the article to be discussed, and Dr. Sayeed will introduce them shortly. Lastly, and in the spirit of an interactive presentation, we encourage audience participation. Please use the question box to post your comments and questions throughout the presentation, and we generally leave about 10 minutes or so at the end of this presentation to address them. Dr. Sayeed, the floor is yours at this point.
So much, Dr. Reid, for that kind introduction. I'm here to talk about a very interesting article that I came across called the Cytomorphologic and Immunophenotypical Analysis of SMARCA4 or BRG1 Deficient Non-Small Cell Lung Carcinomas. And I'm very fortunate to have some of the authors of this study with me on the call today to present this. So how the format is going to work today, I'm going to be sharing a PowerPoint with some of the important findings from this study. And throughout the discussion that I'm going to present, I'm going to ask some questions of the authors that are here with me so you can get sort of their ideas and their thinking behind what was written. So I would like to go ahead and introduce them. So we have 3 of the authors of this study who are gracious enough to join us on this webinar. First, Dr. Shi. She is at Emory University Hospital. She is a cytopathologist as well as a head and neck pathologist. And she's the last author on this study. We also have Dr. Lin from Northwestern. He is in cytopathology as well as thoracic pathology. And we are also joined by Dr. Ogunbona. He is currently a neuropathology fellow at Houston Methodist Hospital. And we're very pleased that all of them are here on the panel to discuss. So please, if you want to direct any questions towards them, we'll get to those at the end of the session. So welcome to everybody who's joining us today. So first, a few objectives of what I want to discuss during this talk. So first, I want to determine the utility of identifying patients with a SMARCA4 or BRG1 deficient non-small cell lung cancer. And throughout this presentation, it's going to be abbreviated as SMARCA4D NSCLC. Next, we want to be able to evaluate the cytomorphology and the immunohistochemical profile of these tumors, which is going to be really important for our current practice. And lastly, we want to be able to examine the benefits of identifying these patients with these tumors. And we're going to talk about the significance of identifying patients in this category. So first, in terms of the introduction for this article, the main objective is to really talk about the inactivation of SMARCA4, also called BRG1, the Brahma-related gene 1. So this inactivation has been demonstrated in a subset of non-small cell lung carcinomas, and BRG1 itself is an immunostain that can help successfully identify this type of inactivation, which makes it a very practically useful tool. And SMARCA4 deficient non-small cell cancers, they tend to present at advanced stage with nodal or distant metastasis and may respond to specific therapy types, which is why it's important for us to identify. So I just want to pause here and ask Dr. Shi, what was the inspiration behind this study? What made you want to look into these types of tumors?
Yeah, this is really a challenging question. So when I encountered some BRG deficient sinonasal carcinoma during my head neck practice, and I have been getting interested in the Swiss NIP signaling pathway. That I look for more information. We submitted for the USCAP for the head and neck portion. Then I decided to look in broad spectrum. Then while I look the literature, then review literature only limited cases reported in cytology on lung non-small cell carcinoma. I thought that's maybe the thing we should investigate. That's how I was curious and then started this project.
Yeah, I love to hear those types of stories when I read articles, because it's always a certain case or a certain thing that sort of sets you on this pathway to study these tumors. So I love these types of studies that are showing you the cytomorphology for something that's been described in surgical pathology. I find them to be really helpful as a cytopathologist. So I'm really excited to be able to present some of your findings. So as I mentioned, the cytomorphologic features are an emphasis of this paper. So SMARCA4 deficient non-small cell cancers have only had rare cytology described in the past. So this paper really focuses on finding more of those cases to see what the commonalities are in the cytomorphologic features. And the belief is if a cytopathologist is armed with the knowledge of these features, it might help to aid in prompt testing for BRG1 loss via immunohistochemistry if you do identify a case with those features. So in this study, 8 cases of SMARCA4 deficient non-small cell carcinomas were evaluated, and they were compared with 8 cases in which SMARCA4 or BRG1 was retained, and they were similar diagnoses of non-small cell lung carcinomas. So briefly, the study was performed by reviewing these 8 cytology cases from the SMARCA4 deficient category and compared against 8 cases in which SMARCA4 was retained. In both subsets of tumors, they were non-small cell carcinoma, and they were retrieved and reviewed from the institutional database search. And these cases were compared cytologically and immunophenotypically. Additionally, they're described the histologic features that were seen on the cell block material. So Dr. Shi, another question about sort of the idea behind this study. Was there an index case or a certain case that came across your desk that you thought, okay, maybe this was a good one to do the stain for BRG1?
Sure, yeah, as I evaluated that, because I have been working on the research and in the head neck and also the submit for use cap, I said, okay, now let's think about other field. Then when I encounter a couple of cases that has some high grade features with it's a non-small cell without squamous and lung markers positivity. Then, however, the A1 is 367 positive. I thought, why don't you just try it? And then I did a INI1 and a SMART Cytomorphology, that's the BRG1. Then it's 10 of the BRG1 loss. So now I discussed with my coworkers, and then 3 of them contribute another 3 cases at this almost same time. Now I submitted, and then I got reviews, great point, very excellent comment that we need that control. So that's why we went back our database and look into, I think, a 3 years span, and because the timelines need to resubmit in months. So now we did that search and found 11 cases non-small cell carcinoma. Then we performed the INI1 and SMART for that BRG1. So it turned out very luckily 8 evenly controlled and positive cases.
That's amazing. Yeah, it sounds like a small number, but it's actually a big number considering how rare this diagnosis is. And after I read this paper, I immediately thought about my own institution and wanting to pull all these non-small cell cancers that are pleomorphic just to see if maybe they are BRG1 deficient as well. So it's a really interesting review of some of the cases that were previously diagnosed as well. So in talking about some of the results from a review of these 16 patient cases, half of them with the BRG1 deficiency and the other half with the retained SMARCA4 or BRG1, all 8 of the patients with the SMARCA4 deficient status had a smoking history of greater than 35 years. So that was a pretty significant finding and confirms findings previously as well. So that was something that was conserved between all of the patients in this deficient group. The mean age was found to be about 70 years old. The mean tumor size, I thought this was an interesting finding. There was a difference between the SMARCA4 BRG1 deficient group and the SMARCA4 BRG1 retained group, in that the SMARCA4 deficient group had an average tumor size of 4.8 centimeters, and these were all lung masses, compared to 7.1 in the retained group. So that was an interesting difference. And 7 out of 8 cases in the SMARCA4 deficient category showed regional lymph node metastasis, which is expected in this more aggressive tumor type. So this is table 1 from your study, and it shows a side-by-side comparison of the two groups, the deficient group versus the retained group, to show some of the clinical features, some of which I mentioned previously. So there was a slight male predominance found in the deficient group, which was an interesting finding. And down here around the lymph node metastasis, you can see more lymph node metastasis seen also in the SMARCA4 BRG1 deficient group as well. And predominantly these samples were from the lung or lymph nodes. So some of the results in terms of cytomorphology. So this was really the meat and potatoes of this study, which I really appreciated. So here's a summary of some of the features that were found on cytomorphology, and I'm going to be showing some images as well. So in SMARCA4 deficient tumors, on aspiration smears, they were found to have predominantly loosely cohesive clusters of tumor cells. The morphology was high grade, as Dr. Shi mentioned. That was first what triggered her to do either INI1 staining or the BRG1 staining. So high grade epithelioid looking cells. They were markedly pleomorphic with prominent nucleoli. There was also binucleation and multinucleation seen in 5 of the cases. 6 of the cases in this deficient group showed focal plasmacytoid morphology, and 2 of the cases showed necrosis. So I'm going to show some of the images here from this study. Some great images of the aspiration smears, both on diff-quick preparation and PAP. So along the very top row, you can see again very loosely cohesive clusters of cells. You can see the more plasmacytoid morphology, these eccentrically placed nuclei, multinucleation, and this anisonucleosis or nuclear pleomorphism. The image here down at the bottom on H, you can see this intracytoplasmic mucin vacuole. So I think mucin was seen in rare tumors from this group as well. Here's a really large enlarged nuclei. You can see this really great exaggeration in the nuclear size, which is why we're saying it's markedly pleomorphic and not just mild or moderately pleomorphic. Dr. Shi, do you want to add anything to this description?
I think you did really good, and with the description, the only one thing I point out today, that's a background necrosis in some cases you can appreciate. Okay,
so maybe like this image here, there's some necrotic debris at the bottom here. All right, very good. So yes, necrosis was also seen in some of these cases.
Yeah. One more is that it gives me this is spindle cells that triggers to do additional immunostain.
Yes, and that's going to be important later. We're going to talk about the spindle morphology and the differential there. So plasmacytoid, spindled, and epithelioid were sort of the main morphologic features seen here. And that's sort of echoed in the cell block preparation and some of the immunostains that were done in this BRG1 deficient group. So you can appreciate the necrosis, as Dr. Shi mentioned, in A, over here, all this necrosis in the background. In B, you can see a little bit more of the plasmacytoid morphology, and again, nuclear pleomorphism, seen again here on C. And E through I are showing some of the immunostains that were done in a few of these cases. So most importantly, BRG1 showed loss of expression. You can see some positive internal control here. And then the cytokeratin or keratin AE1, AE3 was diffusely expressed. Some of these other markers we're going to talk about as part of the discussion, BRM, SOX2, and SAL4. And in contrast, when comparing non-small cell cancers that had retained SMARCA4 or BRG1, the morphology was a little bit different. So when we look at the cytomorphology of this group, they form predominantly cohesive clusters, and they were epithelioid in morphology as well. Here, instead of marked pleomorphism and multinucleation or binucleation, it was more mild to moderate pleomorphism, and there was a lack of necrosis seen in these tumor types. And again, only one group out of the 8 of these showed multinucleated cells. So that seems like a feature that was conserved among the deficient group. So here are some images from the non-small cell lung cancers that had retained SMARCA4 or BRG1. And so again, a little bit more cohesive clusters seen in the top row compared to the loosely cohesive tumor cells that we saw in the example of the deficient group. On Papanicolau staining, you can see F, probably the one case that had the multinucleation, but a majority of them did not. And the pleomorphism here is not as striking as we saw in the deficient group. So a little bit of spindled morphology seen, but overall mild to moderate pleomorphism seen in this group. Do you agree, Dr. Shi? Anything else you wanted to point out from this image?
Yeah, you did all we described here. Yeah, it's good.
Okay, thank you. And here is the cell block preparation and some immunostains from, again, this SMARCA4 BRG1 retained group. So in A, this cell block preparation is showing somewhat pleomorphic cells. So these are a little bit more on the plasmacytoid, maybe focally spindled morphologically. And you can see here in B, you can see some of the cells have a little bit of a clear cell change. So that was something that was previously described in BRG1 deficient thoracic sarcomas, for example. So there were focal cases that were seen in this study that also had that clear cell change seen a little bit better on the H&E. And down here, some of the immunostains. So if you notice, they're sort of similar between these two groups, except for the BRG1. So this retained group also had positive expression of keratin AE1 and AE3. CK7 was also positive, so that helps confirm that it is a carcinoma and not a sarcoma, for example. And here is BRG1. So you can see, unlike the last case, that this is diffusely positive for BRG1. So this is another table, and this table is showing a breakdown and a comparison between the two groups to, again, emphasize some of the morphologic characteristics and specifically the cytomorphology. So we highlighted some of these findings as well in the images, but just to reiterate, so they were, both groups showed pretty cellular aspirate smears. The cohesion was something that separated them a little bit, with more loosely cohesive clusters in the deficient group compared to more cohesion seen in the retained group. The pleomorphism, again, more mild to moderate in the retained group compared to more marked pleomorphism in the group that had the loss of the BRG1. The cell shape, as Dr. Shi mentioned, more plasmacytoid morphology seen in the deficient group, maybe more spindled morphology as well seen in that group. The nuclei themselves, they tended to be more eccentrically placed in the deficient group with bi and multinucleation and prominent nucleolus seen. The cytoplasm, it was moderate, I think, for both groups, so that was conserved between these two groups. And lastly, the mention down here of necrosis and apoptosis. So necrosis and apoptosis both seen only in the deficient group and not in this study when we looked at the non-small cell cancers with retained BRG1. So this slide is meant to describe some of the immunohistochemical findings, which I found to be very interesting in this case. So all 8 cases of the SMARCA4 deficient non-small cell cancers showed similar immunohistochemical profile to the retained group. The important difference being, of course, loss of BRG1. So both of them had staining for AE1, AE3, proving that it's carcinoma in origin, but they're negative for specific markers of a lung primary. For example, they were both negative for TTF1 and napsin-A that you would see in lung adenocarcinoma, and negative for P40 or P63, something you would see in a squamous cell carcinoma. Both had loss. The loss of BRG1 was the one feature that was different between the groups. So loss of BRG1 in the deficient group versus the retained. And this was another interesting finding. PDL1 was expressed in 5 of the 6 tested cases. And here PDL1 expression was defined as low or high. So the group, these 5 out of 6 cases look like they had between 1 to 50% expression of PDL1. So Dr. Shi, in my lab, we don't have a BRG1 immunostain. What would you recommend for pathologists that are listening that don't have a BRG1 in their lab?
Our institution luckily have this antibody then, but it is commercially available, and the stain is nuclear stain that's reliable. So now also internal control can be really good, serve as internal control if encounter the BRG loss cases. So anything from Dr. Lin, your institution?
Hello, we do not have validated, we have not validated SMARCA4 and BRG1, but we try to do that recently, but need time to validate. And in our institute, the NGS, PGX, that panel, the NGS panel that have that BRG1 gene. So if you institute have the big broad panel for NGS testing, you may use the NGS.
So another question for Dr. Shi and Dr. Lin also, when you're working up cases and the morphology is non-small cell and you've done napsin, TTF, P40 or P63, and you've sort of ruled out that it's a squamous cell or a straightforward lung adeno, at what point does it trigger you to think about one of these BRG1 deficient tumors?
Dr. Lin, do you want to start?
Yeah, because we do not have that, the marker, but I know if you see the very high-grade tumor plus cytoid or rhabdoid features, or you see some, the lucid is very polymorphic, you can send out for staining, or you can do the broad panel or NGS.
Yes, in our practice, since we investigate this high grade now, if anything, typically primary pathology would rule out other metastases at the point that we'll add BRG1 and just make sure we have the specific targetable things we can work on for the future.
Yeah, that's, I think, really important, because I think as people order next generation sequencing, it's sort of done on the back end of many cases. And so sometimes the pathologists don't follow up and say, that case that I was pleomorphic, let me check the NGS results to see, was that one that had a SMARCA4 mutation? So I'm guilty of such a thing myself. So I think in the future, that's one thing I want to keep my eye on to see, am I able to make this correlation and find the histomorphology and cytomorphology and then follow up the results and confirm that it was a case of BRG1 deficiency. So I think that is interesting. So our institution, we also do NGS currently, but I'd love to be able to get the BRG1 stain. That would be really much faster to identify these patients and these tumors. So we sort of highlighted some of the key differences in the immunohistochemical stains. This is another table from the article that again shows a side-by-side comparison of the SMARCA4 deficient group compared to the SMARCA4 retained group. So pankeratin, AE1, AE3, positive in both of them, and BRG1 obviously lost in the deficient category and retained in the retained category. Cytokeratin 7, that was a marker that was also expressed pretty much in both groups. And again, napsin A, P40, P63, TTF1, those specific markers of lung carcinomas, adeno and squamous, were not positive in either category. And we mentioned earlier about PD-L1. This is more of a specific breakdown about the cases that were positive and how much so. So again, if it was negative, it was less than 1%, low between 1 and 49%, and high greater than 50%. So interestingly, these cases with the deficient category had more of expression of PD-L1, which again has implications for patient treatment. So moving on to the discussion. So in summary of some of the things that we've discussed, this SMARCA4 deficient non-small cell carcinoma category, these tumors exhibited high-grade cytologic features with marked pleomorphism, possible multinucleation and plasmacytoid morphology. Dr. Lin also mentioned the rhabdoid morphology can sometimes also be a clue that you're dealing with one of these tumors. In contrast, in the retained group, we often saw mild to moderate pleomorphism with round or more polygonal shapes rather than plasmacytoid or spindled shapes. So that could be a clue that you're dealing with one of these tumors. And the immunoprofile in both groups were pretty similar, showing positive staining for keratin with lack of lung adenocarcinoma or squamous cell carcinoma markers. So differentials considered, so because of the pleomorphic nature and somewhat spindled nature of some of these tumors, a SMARCA4 deficient thoracic sarcoma is something that was considered as well because of the similar cytomorphology. I believe one case that was described showed positive MOC31 staining, which helped to favor that it was carcinoma. And currently it's unclear if these two distinct entities are truly distinct or could they be on a continuum, and additional studies probably need to be done to further figure out if they're two things or one sort of umbrella diagnosis. So any insight into that from Dr. Shi or Dr. Lin of how we could separate these two entities? Would it be possible?
Dr. Lin, do you want to start? Also, Dr. Ogunbona, and if you have any thoughts, that'd be great. And he has contributed significantly with this aspect. Dr. Lin, would you want to start?
Yeah, I think that maybe just the only thing that can do is cytocartin. I think if it is cytocartin positive, it's better pan-cytocartin, AUI3, CAM5.2, MARC31, and the Claudin 4 that more favor carcinoma. But for sarcoma, I have a couple cases for thoracic SMARCA4 deficient thoracic sarcoma. I have a couple cases in cytology. Just make cytology. We did, the NGS, then find out. But the thing is, it is negative for epithelial, the cytocartin markers.
Dr. Ogunbona, do you have anything to add?
Yeah, I think just supporting what Dr. Lin has said, so even if cytokeratin is not positive, it's just good to add some other markers for of carcinoma like MOC31, Claudin, because that's one of the things, not being positive for cytokeratin does not necessarily mean that that is a sarcoma. You have to do more to see if there are other markers of carcinoma that are positive. And the thing right now is we don't even know whether these are two separate entities or they may just be like a continuum of one category.
Yeah, I agree. And in addition, there's a morphology like spindle cell component that can think into the differential, consider differential as a thoracic sarcoma category, and that's WHO, I think, suggests to actually our reviewer also suggests to the BRM, that's a BRCA2. So then luckily we got Dr. Hornick's help and to provide that antibody to complete the study, and all the 8 BRG deficiency carcinoma cases all have the BRM retained. Yeah, then also this additional MARK31 or epithelial markers support to favor carcinoma in this specific case.
Right. Yeah, and I think that that's, sometimes it is something as simple as doing a keratin stain or a MARK31 stain to confirm that it is a carcinoma. So this was sort of something I talked about in the Twitter chat last night. If any of the participants from that are here today, one of the questions I asked is, what do you do in routine clinical cases where the morphology is non-small cell? It's negative for TTF or napsin, it's negative for P40 and P63. What's your next step? So I guess part of the answer is it depends on the morphology, and it also depends on how much tissue you have. For me, my next step is always to do a pan-keratin, and if I haven't done it up front, just to confirm that I am dealing with a carcinoma. For you, Dr. Shi or Dr. Lin on the call, what's your sort of go-to when you have a non-small cell lung cancer and it's not positive for, lung squamous markers or lung adeno markers? What's your next round?
Okay.
If it is cytokine positive, just say non-small cell lung carcinoma, then no matter what happens in our institute, we send to NGS.
Mm-hmm.
But some people I know previously used the CK56, those for the squamous cell. But the thing is, I don't think that's specific. And some previous few paper published on CK7 for adenocarcinoma, but I do not believe that the CK7 can be positive for squamous cell too.
So in our institution, we do not run the NGS, for most of the cases unless the clinician requests. So now we typically just by using the all the biomarkers at HEC. If we do have a dual stain, that's Dr. Reid, Michelle Reid created a dual stain P40 and combined with CK5 and P63 and CK5. So then we always use a combination, dual stain, this two of them, and also the TTF and napsin also dual stain. So we always do just 2 charges, but 4 stain ready on one case. So that is very helpful. If anything, as we already discussed, its morphology is just conventional, like a non-small cell. We just sign out. Of course, the clinical correlation to the old rule out to the other side. That's the case on them. Yeah, that's how we perform.
Yeah, I think it's really nice to hear how different institutions handle this problem. I will say at our institution, it's sort of, I guess, depending on how pleomorphic it may look and how complete the patient's imaging might be. If we don't have a good sense of what the imaging is there truly a lung mass or could it be a metastasis? We may then sort of pursue, could it be a metastatic lesion? So I think it's definitely case dependent, but I think definitely going and confirming that there is a keratin that's positive is important to sort of at least put it in the non-small cell carcinoma category and not go down the rabbit hole of could it be a sarcoma, could it be a metastasis, etc. So that sort of brings me to my next point about neuroendocrine differentiation. There was one case that was mentioned in this study that was positive for synaptophysin, but overall the morphology and other immunostains were not supportive that it was a small cell carcinoma, for example, or have neuroendocrine differentiation. So overall, another point to take home about these tumors is that they have a poorer prognosis compared with conventional non-small cell lung carcinomas. And that's really important to the patient's treatment because there potentially could be some benefit to these patients with use of immune checkpoint inhibitors. And this may lead to improved outcomes for these patients if they have a SMARCA4 or BRG1 deficiency. So at our institution, it's not really the practice has not truly been standardized, and I'm sure that's true of other institutions of how these patients are treated. But certainly it's something that the clinicians want to be aware of if it exists. So a question for my panelists, what is your top line diagnosis when you have a SMARCA4 or BRG1 deficient non-small cell carcinoma? Is it going in your diagnostic line? Is it going in the comment? How do you word this diagnosis?
In my practice now, if I have the case with BRG loss, so now I would say non-small cell carcinoma with absent BRG present, and I just say consistent with thoracic SMARCA4 deficient undifferentiated tumor. That's WHO suggested.
What about you, Dr. Lin? Is that your top line diagnosis as well?
Yeah, that have to follow, the new WHO guideline, WHO terminology. But before, I would like to sign out just say the non-small cell lung carcinoma, then see comment with this or that, mutation. Because NGS, you may not only test only one mutation, they may have some other mutation too.
That's true, yes. And I think that that's the sort of the advantage here to having the BRG1 stain, is that it is something that you could potentially include in your diagnosis before it goes for NGS. But it may not be information that you would have when you're signing out the case. So as mentioned in this study, the sample size remains a limitation, though there were 8 cases in this study. Obviously, a review of more cases would be helpful to sort of confirm this, these morphologic findings are reproducible. So Dr. Shi, do you have any studies underway to look into this topic in more in depth or with more cases?
So right now, yeah, since we have this early on study, so we started pay attention to the case that non-small cell with high-grade features to run the BRG1 and just to be mindful and collectively to have cases. Also, I discussed Dr. Lin. He has more rhabdoid features in this kind of case, but in my 8 cases, we did not find rhabdoid features. Maybe that's something to investigate. And another point is that some literature mentioned, even though some tumors that had squamous differentiation, it can be BRG loss. So I think all this study need a collaborative effort and to collect cases, either retrospective or prospectively, and to come as a big cohort study.
Yes, I agree. Dr. Lin, is that something that you plan to look into at your institution as well?
I just do not have time, kind of busy now, but I'm just planning to review the NGS PGDX panel and to find more, maybe lucky to find more cases, because in our institute, for every lung, we automatically order NGS. So hopefully can get more, then have more cases, you may find some more cytologic staining panels.
Yeah, that would be great. I plan to actually do the same at my institution. So if you need another collaborator, let me know. I'm sure we have a number of them in our archives that we've never really looked into. So yeah, it sounds like there is many future studies along this pathway that are in the pipeline, probably requiring a more interinstitutional collaboration. So
because each institute, they may have not, because those are very rare cases, you may not get enough cases.
Right,
Better
yeah.
have more institutes involved together.
Exactly, yeah. A large collaborative study, definitely. So in summary, some of the take-home messages that hopefully you've taken away from this webinar today and might be helpful in your practice is that the SMARCA4 deficient non-small cell cancers, they exhibit high-grade cytologic features with marked pleomorphism, multinucleation, and plasmacytoid morphology. These tumors have positive staining for keratins, specifically AE1, AE3, and lack specific markers of lung adenocarcinoma or squamous cell carcinoma markers. And the prognosis is worse for these patients. They're more aggressive and they have lymph node metastasis compared to conventional non-small cell carcinomas. So the good news is there may be some potential treatment benefits with immune checkpoint inhibitors, and I believe that's an area of active study on the clinical side as well. So as a pathologist, if you are suspecting this type of tumor, this deficiency based on the cytomorphology, you can do a BRG1 stain if possible, if it's available at your institution, to aid in the identification. And as Dr. Lin mentioned, of course, NGS testing may pick it up as well. But the nice thing about the immunostain is it's a much quicker turnaround time, so that's something that would be clinically useful right away. One other thing I wanted to emphasize in reading this is that, you know, we deal in cytopathology with FNAs, and sometimes that's the only tissue available for study. So it's really important that we are the gatekeepers of doing the correct immunostains and getting to the correct category of tumor for these patients. So that's why looking at the cytomorphology, recognizing the morphology, and deciding what needs to be done next is such an important part of what we do every day. So I'd like to thank our panelists for joining me today. Do you have any concluding remarks or other take-home messages you'd like to emphasize for our audience?
One thing I want to add is that there's no standard therapeutic targetable treatment so far in this regard, this deficiency carcinoma. I communicate with pulmonary immunologists and our expert in the lung pathologists, but that's you know, probably some clinical trial may investigate some targetable markers, and then the utility of BRG1 can be more essential.
Yeah, and I would just add that in a number of labs, INI1 immunostain is available, and then we often tend to forget about BRG1. So not only in the lung tumor, BRG1 is often lost in some other tumors, like in the brain. We have the rhabdoid tumors. So I think if we have INI1 in your lab, you should also try to have BRG1. Thank you.
Thank you.
Yeah, very excellent presentation, the summary. Thank you very much.
Thank you so much. We have just some time to go through some questions. If there's any questions for the audience, Dr. Reid, do you see any questions for us?
Yes, I actually thank you again, everybody. This was very nice, very concise, to the point, and very helpful. We have two questions, one of which I think has been answered, but I do read it, and that's about the specific therapeutics for this type of tumor, which we kind of discussed that there is no specific therapy at the time. So I think that's something that was addressed. The other question, and there's more coming, but one of the other question was that, was your PD-L1 done on alcohol fixed or on formalin fixed tissue?
In our institution, the cell block direct go to the formalin fixed, so we have validated for the formalin fixed cell block.
Very good. Anybody else doing it differently? Because I totally agree with you. I'm in a big reference lab at the current time, and that's what we kind of make sure that we do the PD-L1 on the ones that are directly alcohol fixed for the specific PD-L1 for lung cancer, for example, when we do it. Otherwise, it would be a generic PD-L1 if the clinicians insist on having it, and I don't really know how do they use that information. But for giving the score and what's known as part of the standard of practice for PD-L1, we do require a formalin fixed tissue. Even if it is a cytology, we do look at the gross description and saying whether it was formalin fixed, not just alcohol fixed. So that's a good point. So let me see. So it says, what is your experience in regards to tumors showing BRG1 loss on IHC but does not show the mutation on NGS?
That's a good question. I don't have the comparison. I could look into it to see if any lung case have been done NGS to see if there's a match. That's a great question. Thank you. And Dr. Lin, it does not have that. Yeah, Dr. Lin, do you have anything to add?
No, I do not have the experience, for the compared immune staining and NGS. That's a good question because we do not have the antibody so far. We are doing validation now, but have not been validated.
Dr. Sayeed, I see something for you to look into. You seem to be interested. You said that you're trying to look at
the person asking this question is actually the IHC director of my lab, so sounds like a project for both of us.
I think this is the beginning of it. We've witnessed it. That's good. Very good. Very good. Let me see if there is any other questions. I do not see any other questions at this point. And so again, we are at 1:49. I think people who wanted to ask questions, they've already done their questions, but we can kind of in the wrap up, as you guys said, it is a rare tumor, so definitely there is a lot need to be learned about it as we kind of have recognized it in the practice. So now it's like everything else, it starts small, but then it may grow because now we're more cognizant of looking for those things. And the analogy that I use usually is the different classifications for kidney tumors. When I was a resident, you were just clear cells and papillary. You may had a chromophobe and the usual question of chromophobe versus oncocytoma, but that was it. But then when I got to practice geopathology, oh my gosh, the sky is the limit. So, and every day there is more and more coming. So probably there are more cases to be seen that we did not recognize before, but that's the beauty of learning more and kind of looking into things. And again, at the end of the day, to find the target for treatment in these patients, especially for diseases that are having very poor prognosis and very aggressive behavior. So. Very good. I guess if you guys don't have anything else to share with us, I think we can give you 10 minutes back to your day. And this was great, actually. I learned a lot, and it was very well presented, both at the level of writing the paper by the authors and by presenting by Dr. Sayeed, because that to make it more interactive and understandable. So
yeah,
thank you very much.
Yeah, thank you, Cassie, for moderating, and thank you, Dr. Sayeed, for a great summary of our study. It's very informative and get a key point. Yeah, thank you. Thank you, all our panelists.
Yeah, thank you, everybody.
Thank you, everybody.
Thank you. Have a wonderful afternoon.
Yeah, bye-bye.